Good morning. Thank you for the opportunity to present on clinical trials for prevention of cisplatin-induced hearing loss, current study results, potential practice applications, and future challenges. I do scientific advisory for Autonomy and Sensorion, advising on potential study designs under a service agreement whose terms are strictly limited with Children's Hospital Los Angeles. And I will discuss off-label use of sodium thiosulfate as a potential therapeutic option for preventing cisplatin-induced hearing loss. These are the key abbreviations that I'll be using in the presentation, most of which are pretty standard. So over the next few minutes, what I'd like to do is to present chiefly focusing on the two studies of sodium thiosulfate that have recently been published, ACCL 0431, conducted by the Children's Oncology Group, and Siop 6. I'll then discuss how we might be able to interpret these results to lead to potential practice applications, and then finish by discussing some of the considerations for future otoprotection research, considering preclinical and translational issues, trial designs, and agents and routes of delivery. First of all, sodium thiosulfate may be familiar to some of you. It's a thiol-containing antioxidant, which is rapidly excreted after IV administration. It is commercially available for cyanide poisoning, and it has been shown in extensive preclinical work to provide otoprotection but not tumor protection when it's given in a schedule-dependent fashion 4 to 8 hours following the completion of cisplatin in a number of pediatric tumor models. At the time that ACCL 0431 and Siop 6 were launched, there were data published showing that STS provided otoprotection in adults who were receiving intra-arterial high-dose carboplatin for brain tumors, and it had been used in some children and was found to be well tolerated for the same purpose. I'll first talk about ACCL 0431, and the overview is that this was a multi-center, open-label, randomized clinical trial that was conducted between June of 2008 and September of 2012 at 38 participating COG sites in the United States and Canada. This was a trial that enrolled patients 1 to 18 years of age with a variety of diagnoses, all of which were treated with cisplatin, requiring a planned cumulative cisplatin dose of 200 milligrams per meter squared. Their patients were required to have normal audiometry at baseline. This was a proof of principle study from the very beginning, designed to determine whether there was any signal from STS as far as preventing hearing loss was concerned. And so the key outcome assessments and comparisons reflected that. The primary outcome was hearing status at 4 weeks following the final cisplatin dose, and if for patients who were to undergo transplant, particularly if it included carboplatin like the neuroblastoma patients, the hearing was obtained prior to the transplant. We used the criteria for the American Speech, Language, and Hearing Association, or ASHA, which is a binary yes-no outcome measure of hearing loss as either present or absent. We used central blinded review, evaluating the proportional incidence of hearing loss and comparing them by the randomized arm using the chi-squared test. One of the key secondary aims was monitoring survival, and I say monitoring because this was done in an informal way. The sample size calculations were all determined around the outcome of hearing loss, and so it would have required a major difference between the two randomized arms to detect a difference. We looked at survival probability using Kaplan-Meier and compared them by the log rank test. This is the study schema for ACCL 0431. The patients who were treated on a cisplatin regimen were randomized 1-to-1 either to observation or to receive STS. If they were on the observation arm, they received their cisplatin according to their primary treatment protocol. And if they were randomized to STS, they received their cisplatin according to their primary treatment protocol, along with STS given at the dose shown, 16 grams per meter squared, 6 hours following each cisplatin dose. And as I said before, the primary endpoint was audiometry 4 weeks following the final cisplatin dose. These are the patient characteristics for that sample. The target enrollment was 135 patients. We enrolled 131, and 125 were eligible and randomized. This shows the host characteristics, which are largely similar between the two arms. This slide demonstrates the disease and treatment characteristics between the two randomization arms. As you can see, consistent with the study design, there were patients enrolled with all of these different tumor types, which were more or less balanced between the two arms. I'll speak to this in a few minutes, but we did a post hoc evaluation of extent of disease, and those were roughly equal between the two arms as well. These patients received a substantial cumulative dose of cisplatin, almost 400 milligrams per meter squared on each arm. This is the hearing loss by randomized arm in ACCL 0431. As you can see, under the observation arm, about 56% of patients developed hearing loss by the ASHA criteria, compared with about half that, 28.6%, in the patients randomized to receive STS. Adjusting for the stratification variables, adjusted odds ratio for hearing loss in the STS group was 70% less if they received STS. This demonstrates hearing loss by randomized arm according to age, and as you can see, the effect of protection by STS was particularly strong for patients who were less than 5 years of age, where the baseline incidence was about 73%, and it was reduced to 21% if they received STS. When we monitored event-free and overall survival, this was the group as a whole, all 125 randomized patients. Event-free survival is shown at the top and overall survival at the bottom. There was no significant difference between the two, but if you look closely, we can see some separation of these curves, and the log rank p-value was 0.07. We were a little bit concerned about this, and we wanted, within the limits of what we could do with this study, we wanted to retrospectively try to understand what might be possibly explaining that. So we had the patients classified at the sites as either having localized or disseminated disease, and we looked at their event-free and overall survival stratified in that fashion. This shows the results for the 77 patients who were determined to have localized disease, and as you can see, there is no difference in the event-free and overall survival curves for that group. These are the 47 patients who were deemed by the site to have disseminated disease, and there's no statistical difference in the event-free survival, but the overall survival did show a separation of the curves such that the patients who had STS appeared to have an inferior overall survival. Again, I'll speak to this in a moment, but this was an unplanned post hoc analysis. This slide here demonstrates the distribution of patients by disease type and by their extent of disease by randomized arm. And as you can see, they're fairly close. There are potentially some differences between the two arms in the neuroblastoma category, where actually there were more localized patients on the STS arm and some more disseminated on the control arm, which actually might have favored an outcome with STS. However, it's very, very important that we don't overinterpret these data. And as I've stated before, there are many, many limitations to this post hoc analysis. It was a crude classification across multiple tumor types. These reports were not reviewed centrally. The disease burden of each patient was not captured, and perhaps most importantly, there are important biological features that influence outcome that may not have been distributed evenly between the two arms, but were not captured in this post hoc analysis. I think the bottom line that we've reached is that this is a cautionary observation, but is not definitive. As one explanation for the outcome in disseminated disease, we wanted to do what we could to understand the things that we could get at. And so in data that are not part of the published analysis, I did communicate with the sites where 12 patients at 9 study sites who had relapsed disease with disseminated disease and had been randomized to STS could be analyzed. And the question that we were trying to answer is whether there might have been a difference in the interval between the end of cisplatin and the administration of STS in some sort of systematic way in that group. We had data from 10 patients from 7 sites, and as I said, this was not part of the published published analysis. In summary, what it shows at the bottom under the summary is that over 77 doses of STS and over 32 courses, the mean interval was 6.6 hours, which is right on target for what the protocol required, with a range of 5.5 to 11.3 hours. So it did not appear to be any sort of systematic bias toward shorter intervals for this group of patients. I'd like to switch now to the sodium thiosulfate for otoprotection for cisplatin-induced hearing loss as reported by Siop, and I'd like to acknowledge Dr. Brock for providing these slides for us. So the primary endpoint for that study similarly was the development of grade 1 or greater hearing loss according to the Brock criteria, which was determined at the end of treatment at an age of at least 3.5 years. The statistical considerations similar to the COG study were powered around the hearing loss outcome, but an important secondary endpoint that was being followed was event-free and overall survival. This is the study design for Siop, which shows that the patients were randomized up front either to receive cisplatin alone or cisplatin plus STS in a similar fashion given 6 hours after the completion of each cisplatin dose. The trial was run from 2007 to 2014 at 52 centers in 12 countries worldwide. These are the patient characteristics for the Siop cohort. The average age, or the median age rather, was 13 months with a similar range, and the other characteristics are quite similar between the two arms. These are the adverse events that were detected on Siop. The percentage of all of these complications was relatively low, about 10% or less, and it was fairly evenly distributed between the two arms. These are the hearing outcomes for Siop for the proportion of patients who developed grade 1 or greater hearing loss by the Brock criteria. About 63% of the patients who received cisplatin only, compared with 33% of those who received STS was noted, and this was statistically significant. And a median of 3 years had passed between when the patients reached an old enough age to have their hearing test done. This slide here shows the distribution of hearing preservation or loss by grade. And as you can see here in red, the cisplatin sodium thiosulfate group had a much higher proportion of patients with no detectable hearing loss. And from grade 1 and higher, the STS receiving patients had a lower proportion of hearing loss. This is the event-free and overall survival that was noted on the Siop, and as you can see, with event-free survival on the left and overall survival on the right, there was no difference, and they were both very good in both cases. So when we try to put these two studies together and understand what they're showing us, how can we summarize the two side by side? First of all, both trials have showed a significantly less hearing loss with a similar magnitude of effect, remarkably similar actually, that was statistically significant. When we look at the survival outcomes, Siop clearly showed that there was no significant difference, and all of the patients of note were localized disease or standard risk disease for the classification for hepatoblastoma. As I've shown you, we've had a little bit more trouble sorting that out for ACCL 0431, but in the post hoc analysis, it seemed clear that there was no significant difference in either event-free or overall survival in the localized patients. We do think it's important to interpret these two studies together, and so when we try to draw conclusions from these two trials, what can we say? We think that these two trials together showed definitively that STS does protect against cisplatin-induced hearing loss and that the effect appears to be greatest in young children. STS does not appear to reduce survival in standard risk hepatoblastoma or other localized cancers. And as far as disseminated cancers are concerned, there's no conclusive evidence that STS lowers survival, but carefully designed studies assessing STS in disseminated disease are warranted and needed. So how can we use this information to potentially inform practice applications? First of all, we think that STS can be considered in patients. It's a matter of balancing risk. Those who are at the highest risk for hearing loss by the factors that we now know are predictive, such as young age and high cumulative dose, or perhaps diagnoses that have historically high incidence of cisplatin-induced hearing loss, and patients who are at the lowest risk for cancer treatment failure, so standard or lower risk disease with whatever classification system is appropriate for that cancer, lower biological risk, and perhaps a historical event-free and overall survival of more than 90%. But it's important also to take into account other relevant clinical factors that should play into the decision, such as other sensory deficits like vision loss, existing hearing loss when they start treatment, concurrent radiation therapy to the cochlea, and also what is their access to hearing assistance technology, which is particularly important in low-income countries. So we feel that using this information to inform us now that it is reasonable, based on the data that was clear from the Siop trial, but extrapolating that to other localized cancers based on the data for ACCL 0431, we think it's reasonable to consider using STS in patients who have localized disease. As I've said, those with disseminated disease in all of these categories need further study and carefully designed trials, and there are some other challenges and considerations that need to be taken into account. But there are caveats and questions that remain. For example, there are uncertainties about the role and relative importance of other factors. It may not just be cisplatin cumulative dose. There's evidence to suggest that cisplatin schedule, fractionated versus single-day regimens, that individual dose is important as well as cumulative dose. Dr. Brock already spoke to the issue of genomic susceptibility that we need to learn more about, and then the concurrent use of ototoxic medications. It's important to point out that some regimens use cisplatin infusion times that run longer than 6 hours, and if STS is to be considered for those, the cisplatin needs to be reduced to 6 hours. And then it's always going to be important in these discussions to value the views of parents and patients in weighing the risks. I'd like to close with just a few comments about considerations for future otoprotection research, because we truly feel this is not the end, but rather the beginning. So in terms of bringing together preclinical and translational research to the clinical trials that they would be destined to inform, the goal should be close integration with the anticipated clinical trial. One point that's important to understand is that when we're using animal models to study otoprotection and tumor protection, currently there is no single animal model that actually can do justice to both. And so it's a fairly complex two-model system that needs to be used to screen agents first for otoprotection and then potential tumor protection if that's a concern mechanistically. And once those animal models are undertaken for tumor protection, we need to use physiologically relevant doses of both the otoprotective agent and the cisplatin, given by the same dose schedules, the routes, and using the same cancer types that will be the subject of the clinical trial. And there should be important consideration given to screening other chemotherapeutic agents that are in the clinical regimen. When we look at the two major designs that are represented by these complementary trials, ACCL 0431 and Siop 6, we can classify them as either being freestanding or non-linked to a trial, which is the COG example, or one that's embedded and linked to the clinical treatment regimen, which is the Siop 6. Clearly, in the embedded or linked, you've got a homogeneous population in all respects, diagnosis, age, and access to many treatment details that are not available if it's a freestanding study on which patients are coming from various treatment regimens with different diagnoses and variable age. When we look at the strengths and limitations of each of these, there are some for each. For the freestanding non-linked, it does offer the advantage of potentially faster accrual of patients, but on the other hand, the embedded linked model is better positioned to address unexpected interactions, such as the ones that we encountered with the ACCL 0431. One challenge with the embedded linked model is that it may be challenging to achieve sample sizes that are needed for conventional non-inferiority trials, and so we're going to rely on our biostatisticians to help develop creative approaches where we can answer these questions with smaller sample sizes. In the thinking that we've done about this, It may be that each of these designs actually has an ideal sort of use for agents where there really is no empiric or mechanistic concern about chemotherapy interference. Indeed, perhaps the freestanding non-linked model is reasonable to use, but for any studies that would require close observation and understanding of treatment decisions that are made and dose modifications with the chemotherapy for those that may have an empiric or a mechanistic concern about interference, embedded or linked models like Siop-6 are probably advantageous. I'll close just by mentioning very briefly with one slide a route that is being evaluated and was touched on by Dr. Brock, the intratympanic injection. There have been two studies that have recently been completed in this regard, one published and one in preparation. The published trial was from Iran using N-acetylcysteine in 60 patients, most of whom were adults with adult cancers. The 10% N-acetylcysteine was injected in both ears of the patients. They were randomized by patients compared to a control of dexamethasone. And with 1 to 3 injections being given, what they found was at the highest frequencies there was benefit for N-acetylcysteine in protecting hearing. The other study is much smaller, of 11 patients conducted in the United States, sponsored by Autonomy, a multi-center trial that enrolled 9 patients with neuroblastoma, 2 with osteosarcoma with a relatively young age. This used a different design of randomizing by ear, in which the patients received dexamethasone in a gel in the treatment ear and nothing in the other ear. The patients received up to 1 to 3 injections. This was a feasibility and safety study that did hit those endpoints and showed that this is a reasonable platform that can be carried out, but efficacy was not seen at the dose that was tested with the dexamethasone. So to conclude, we feel that STS does protect against cisplatin-induced hearing loss and should be considered for routine use in at-risk children and patients with localized and lower-risk cancers. We feel STS should be considered for further study among patients with disseminated cancer in carefully designed equivalency trials that are linked to protocol-defined treatment regimens in the embedded model that I mentioned before. And then finally, as I said, we do truly feel that STS is not the end of the story, but rather only the beginning, and that active research should continue seeking additional agents that should be developed for even greater efficacy, and as well as expanded use in additional populations that currently can't be treated with STS. These include N-acetylcysteine systemically, intratympanic and oral routes, agents that have alternative mechanisms of action that don't necessarily present conceptual concerns about tumor protection, and then finally, how do we use these agents in combination to develop even more effective regimens? I'll close here by acknowledging several individuals and groups that have been critical for the research that I've shown here, and I'd like to particularly point out the contributions of Dr. Ed Newelt, who did the foundational work with STS that led to these clinical trials. Thank you very much.